FR2 से बोल रहे हैं। हाँ। Next is FR2. FR2 is used in class 2 Div 1 and class 2 Div 2 cases. They are most widely used. In this appliance, upper lingual wire is incorporated to prevent the lingual tipping of the upper anteriors. And this lingual wire was earlier called protrusion bow. Is canine clasps that do not wrap around the canine and thus are less likely to interfere with eruption. So this is how it is fabricated in the FR2 appliance, canine loop. It is present only on the buccal surface as a loop. Then the maxillary molar rest is bent mesially to lie in the occlusal fossa of the deciduous second molar. Now next is FR3. FR3 is used in class 3 malocclusions. In FR3, the lip pad is situated in the maxillary arch instead of the mandibular arch. It is situated in maxillary of the labial vestibular sulcus. It eliminates the restrictive pressure of the upper lip, exert tension on the periosteal attachment in the depth of the maxillary sulcus to stimulate the bone growth. So in case of restricted maxillary growth, this can exert tension on the periosteal area and will result in formation of the bone. So the palatal bow in the FR3 appliance is present distal to the first permanent molar and occlusal rest present on the lower molar instead of the upper molar, thus allowing free movement of the upper molars. So in FR3, the anchorage is taken from the lower arch and not from the upper arch, so that free eruption of the upper molars will be allowed. Construction bite for FR3 appliance. The procedure of taking the construction bite is done by recruiting the mandible as much as possible with the condyle in its most posterior position. The vertical opening is kept to a minimum to allow lip closure with minimal stress. FR4 appliance, it is used for correction of the open bite and bimaxillary protrusion into the mixed dentition. The wire component, the appliance fabrication is similar to FR1 and FR2, but no canine loop and protrusion bow is given in this case. Palatal bow is similar to FR3 with passing distal to the first molar area, and four occlusal rests are present to prevent the eruption of the posterior teeth. And FR5 was a modification which was given by Albert H. Owen. It is indicated in long face syndrome having a high mandibular plane angle and vertical maxillary axis. In this FR5 appliance, a posterior block in the posterior region is given. The appliance consists of addition of posterior acrylic bite block to arrest the molar eruption. Since the growth pattern of the patient is vertical, and also a headgear tube is incorporated which accepts a phase bow for an occipital pull headgear. Modifications of the functional regulator appliance. First is modified function regulator, which was given by S. Haynes, Edinburgh, and Great Britain. The palatal acrylic support and continuous buccolabial acrylic construction instead of separate buccal shields and lip pad. In this modification, was not present. A complete acrylic part forming the buccal shield and the lip pad was fabricated. The appliance is not locked into the mesial embrasure of the maxillary first molar by a cross palatal bar. Now next is capped Frankel appliance, in which in lower anteriors the lower lingual plate, the acrylic part was extended for capping of done to control the labial tipping of the mandibular incisors. Next is hybrid function appliance, which was given by Dr. Peter and Dr. Catherine in 1980. Are specifically and individually tailored for every patient. It is like combination of the activator, Bionator, and this Frankel appliance can be used on one side of an FR, but maxillary, posterior bite plane, and mandibular incisor capping like an activator is used. Then the clinical procedure for the fabrication of the Frankel regulator appliance. First is the visual treatment objective, then is impression making, construction bite, and fabrication of acrylic and wire component. So VTO should be done before the fabrication of the appliance. Now it gives a clue to the operator regarding the importance in facial appearance and profile. So in this picture, first is this patient has a class 2 div1 malocclusion. Second is when the protrusion has been done, 3 mm of mandibular protraction has been done, and in the third picture, 6 mm of mandibular. Video can be done to see the treatment outcome that can be obtained. Now, next is construction. First, placement of separator is indicated. Appliances to be fabricated. This is to make space for the wire component in the upper arch. Now, seating grooves in the maxillary model for permanent dentition in the between the first permanent molar and second deciduous molar, and next is the first permanent canine and the first deciduous molar. So, notching in the deciduous dentition can be done. So, this is an article about Regulator appliance. So, is the same instrument used to notch the teeth on the model and in the patient? So, Dr. McNamara answered that no, usually the teeth on the model will be notched with a knife or a file by the laboratory technician. When the appliance is returned from the lab, it is the clinician's job to duplicate in the mouth the notches on the teeth on the model. So, the notches which are made on the between the teeth, it should be uh, it should be duplicated in the mouth by the clinician. Now, the clinician does not notch the teeth before taking the impression. Can this notching be done before taking the impression, before sending the appliance to the lab technician? No, if that is done, the space is often closed by the time the appliance is returned from the lab. One would find it is convenient to notch the teeth at the time of appliance delivery. Now, next is impression making. During impression making, laterally and anteroposteriorly. Impression should reproduce the whole alveolar process to the depth of the sulci, including the maxillary tuberosities for the extension of the buccal shield and the lingual pad. Then working model pour up and trimming. So cast carving should be done shield part. Now tripping for buccal shields, sulcular depth must be 10 to 15 mm above the gingival margin of the posterior teeth. Allows optimal extension of the buccal shields for all possible appositional growth. And trimming for lip pad. So this is the real depth of the sulcus. Adequate amount of carving should be done so that the lip pad, which will be made later, it will present vertically after the carving, and the lowest margin. So that is the correct way of carving, in which after the fabrication of the appliance, the lip pad should lie vertically and not like that which is shown in the third picture. Then construction bite, advancement only by 2.5 to 3 mm, vertical opening only large enough to allow crossover wires to pass through the interclusal space without contacting the teeth. Anteriorly, the advancement should not be more than end-to-end bite. Then fabrication of the wire after the complete the construction bite, taking the construction bite and adapting the wax relief for the buccal shield and lip pad, lab technician for fabrication of the appliance. So what is the mode of action of Frankel? 3 modes of action. First is active muscular involvement, proprioception, that is because of the active advancement of the mandible to edge relation. Second is viscoelastic hypothesis, that is the periosteal stretch and lip pad or buccal shield. That is a formation of the. And next is screening deleterious forces by the buccal shield and the lip pads. And clinical management of the appliance, for the first couple of weeks, it should be the patient should wear it for 2 to 4 hours a day because of the heavy appliance. Then the next period is 3 weeks. After that, from third week onwards, the patient should be given it for 4 to 6 hours a day. And after 3 to 4 months of wearing it, full-time wear is indicated. The time interval between visits should be 4 weeks. As treatment progresses, there should be a gradual improvement in the facial appearance. And during visits, following points should be seen. First, stabilizing the appliance on the maxilla at first visit is absolutely essential. We have to see that if the appliance is getting anchorage from the maxilla or not. If it is stable on the maxillary arch, then for no tissue irritation. Lip seal exercise should be taught to the patient during the. And then during each visit, the patient should be motivated for wearing the appliance. It is indicated in mixed dentition period with growth spurts, skeletal class 2 malocclusion with positive VTO, functional class 2 malocclusion in a horizontal or neutral regulator appliance can be used. The advantages of Frankel regulator appliances: elimination of the abnormal force because of the buccal shield and the lip pad. Then treatment, it can be initiated at early age in the mixed dentition period. The frequency of the patient visit is less. They do not interfere with the oral hygiene. And cooperation of the patient is essential. They cannot be used in adult patients where growth has ceased and without individual tooth movement and therapy. Now, what are the studies done on the Bionator and FR appliance? The treatment effects produced by Bionator appliance: comparison with an untreated class 2 sample. It was published in Journal of Orthodontics in 2004, in which 44 samples were there, 22 control and 22 experimental. Then the cephalometric parameters were analyzed, and it was concluded that no effect on maxillary growth in both the groups. So Bionator appliance is having no effect on the maxillary arch. Mandibular length was increased in the experimental group with patients who were given Bionator appliance, and growth pattern and low anterior facial height was not affected in both the groups. Then this review article on functional appliances, which was published in 2017 in Indian Journal of Dental Sciences. This review was limited to 3 appliances: activator, Bionator, and twin block appliance. So the comparison that was made was the mechanism of action of activator was the activation of muscles. Bionator was to modulate the muscle activity with dominant role played by tongue, and twin block was to proprioceptive stimulus to growth. Versatility: actor can't perform functions such as speech, mastication, and deglutition because of the bulky design. Bionator, speech is possible, but patient can't eat. And wear time: activator nighttime wear, Bionator day and nighttime wear, twin block 24 hours wear is indicated. Then patient acceptance: activator monoblock rigid appliance, so patient acceptance is less. Bionator more elastic with freedom of movement in oral cavity, it is less bulky. And twin block acrylic plates with bite blocks with maximum freedom of movements in the oral cavity. Vertical bite opening: activator adequate, so vertical bite opening can be modified according to the growth pattern of the patient. Bionator, negligible or minimal vertical bite opening is required, and it can be changed. Skeletal and dentoalveolar changes: activator both changes are seen. Bionator more dentoalveolar, and in twin block more skeletal changes are seen. This is an article, comparative study of the Frankel and Bionator appliance in the treatment of class 2 malocclusion, which was published in American Journal of Orthodontics, Dentofacial Orthopedics, and they concluded that both appliances don't have any restrictive growth on maxilla, and increase in mandibular length was seen in both appliances, but it was higher for the Bionator appliance. So I would like to saying that proper diagnosis will always determine which appliance should be given. It is very important to find out the etiology, the cause of malocclusion. If it is because of improper functioning of the tongue, then Bionator should be the appliance of choice. And if perioral musculature hyperactivity is present, then Frankel regulator should be done. These are the references. Thank you.